have to identify, and I have made it, I shall be writing a number of them in a very concise manner. So it will be approximately 3 to 4 pages of writing, which will cover up a lot of areas. So we will be starting from the respiratory system. Respiratory system and basic sciences will be starting from it. And if we look at the control of the respiration, if the control of the respiration, so there are number of controls that we actually have to think of. One is the central control we have, and we have also chemoreceptor controls. Chemoreceptors are also of two types, that is central chemoreceptors and peripheral chemoreceptors. And the central chemoreceptors are usually in brain, and peripheral chemoreceptors are in the aortic body and the carotid body. Just a brush up for many students might forget these things. Okay. So then what we also have, we have a number of pulmonary receptors, so on the basis of which respiratory system works. So regarding central receptors, there are certain areas of central receptor. One is respiratory center in the medulla, so medullary center we have. One is respiratory center in the pons. So in pons also there are two centers. One is in upper pons, as per the classical theory of respiration. This is so that is pneumotaxic center. Usually question do come from the classical theory of this, and the lower pons is the apneustic center. Now coming to the peripheral one, we have central peripheral. Remember very importantly, central peripheral chemoreceptors, they act more on certain things like H plus ion concentration in the CSF. That is the primary driving factor for central chemoreceptor. This is a question. And regarding peripheral chemoreceptor, they worked mostly to the PCO2. That is more important, and to some extent the H plus ion, and very rarely PO2. So that's the whole thing by which they are stimulated, is the lower PO2 that can stimulate them. And regarding the pulmonary receptor, if we look at the pulmonary receptor, I would also suggest you to just take a small note simultaneously, because it will cover up a lot. So pulmonary receptor, a number of receptors are there. Like we can have the stretch receptors. So stretch receptors are basically associated with the Hering-Brewer reflex. Hering-Brewer reflex. So what they do, usually this reflex is a kind of a negative feedback, where if there is a distension of the lung, distension of the stretch of the lung, so distension lead to slowing of respiratory rate. So basically there's a vagus nerve stimulation, and ultimately there's a slowing of the respiratory rate. That is through the stretch receptor present in the lungs. Then we also have the irritant receptors. And irritant receptors, it is actually the chemoreflex, where we can find that if these are stimulated, we can see some bronchoconstriction. So these are basically chemoreceptor. We are not going into much detail. Much details are not also required, but a brush up of this is very much important, because a lot of questions in respiratory you can find from here. And the third one is juxtapulmonary receptors or juxtacapillary receptors. So basically these are the J receptors. So juxtacapillary receptors. So this is this causes some stretching of microvasculature. You have to remember one important thing. Usually these J receptors, they are not working in normal condition. Very important area where J receptors are actually found. This is they are active in case of high altitude, or they are active in case of pulmonary edema, or they are active in case of if there is alveolar edema. So these are the times. So ARDS also some J receptors pathology we can find. Very deep knowledge are not required for MRCP part 1 regarding this, but overall general knowledge like IDS you must have. So then we are moving into some more basic sciences, and specifically the respiratory physiology. So certain topics we need to know. One is Bohr effect. What is Bohr effect? Basically just the basics. Many of you might not be brushing up in recent times. So basically Bohr effects is kind of increased PCO2 that leads to one thing, where increased PCO2 leading to decreased oxygen affinity of hemoglobin. So the more acidity, the more PCO2, oxygen binds less with hemoglobin. Then we have the Haldane effect. We have the Haldane effect. And Haldane effect means increased PO2. That means leading to decrease CO2 affinity of hemoglobin. So basically, increased PO2 will displace CO2 from hemoglobin. So that is the Haldane effect. So basic Haldane effect is like that. And then another very important idea is the chloride shift. So chloride shift that usually happens in the capillaries. Chloride shift that happens in the capillaries. This usually happens in the peripheral circulation. So what is chloride shift? Basically carbon dioxide that can go into the RBC. We know that RBC is a biconcave shaped structure with a semi-permeable membrane, but semi-permeable membrane, be it semi-permeable, but still carbon dioxide can easily, freely diffuse into the RBC. Once it is inside the RBC, this combines with CO2 and H2O plus, and there's an enzyme, we call it carbonic anhydrase enzyme, that makes two things like H plus and HCO3 minus. This H plus combines with hemoglobin, so basically it becomes a reduced hemoglobin, and HCO3 that moves out, see HCO3 that moves out in exchange of chloride. So HCO3 that moves out in exchange of chloride. So basically what happens, what we get chloride ion enters into RBC. Now chloride is osmotically active, being an ion, it's a particle, it's an osmotically active particle leading to entry of water into RBC. So what we find in RBC, so basically the RBC volume that increases. So one very important thing that there is 3% increase in MCV in peripheral venous and capillary blood. Peripheral venous and capillary blood. So this happens due to this chloride shift. We also call it as hamburger phenomenon. Hamburger phenomenon. So this is about this, and this happens in the periphery. There's another concept that's just the opposite reaction happens in case of the lungs, where more and more oxygenated blood is present, and what we find over there, that is the reverse chloride. So just that happens in the lung, that is sufficient for you. Other thing, I do hope that you can derive in the exam. Now we will be moving to certain just covering the pleural effusion part in the MCQ areas. So here you can take down this lights criteria, which is basically gives us an idea whether it is a transudate and exudate. You can take a snapshot of this criteria, because we will be doing it in the next day MCQ, but we will not be having time for the theory part discussion. So you can take this one. One more important thing, if it's a bilateral, mostly it is a transudate. If it's unilateral, mostly it is a exudate. Again, exudate, they have a higher protein value, and transudate have a lower protein value. And usually, if it is intermediate protein value, Light's criteria fits the best. So there also we check for the serum protein and fluid pleth protein, serum LDH and pleth LDH. These are the things we usually check for. So this is about the pleural effusion. This will help you out. You can take a snapshot regarding this. Okay, now we'll be moving to some questions. So this question, you can also open up your mic. So a 38-year-old man reviewed in the respiratory clinic complaining of episodic wheezing while playing rugby. So there is no history of cough, atopy, or smoking. He is generally fit and well and has no past medical history of note. Clinical examination is unremarkable because it is in between. It's basically in the time when he is not having any symptoms. So which of the following should be arranged to investigate his symptoms? We have pheno and spirometry bronchodilator reversibility, chest X-ray, spirometry bronchodilator reversibility, methacholine stimulation, and a trial of corticosteroids with FEV1 measurements before and after. So basically nothing but the earlier way. So what do you think? Any idea? Okay. So basically, I don't know whether they were connected or not. Anyway, so basically, this is a case of asthma, and as per the British Thoracic Society guidelines 2016 and NICE guideline 2017, the idea is Veno plus spirometry and bronchodilator reversibility. We have discussed about this a while ago. More than 17 years of age, we will be going for this. 5 to 16 years of age, we will be going for first spirometry. So the age is important. It is a 38-year-old person. So it's a spirometry plus BDR. If it is symptomatic for, it is positive for asthma, that means reversibility is there, then definitely there is no further need of any other investigation. If it is inconclusive, then we need an fractional exhalation